Hi, my name is Carl Lang, and I'll be your host as we explore ways to decrease risk factors associated with UCL injuries in the overhead thrower. Our PICO question will be, among overhead throwing athletes, will a kinetic chain injury prevention program decrease the likelihood of ulnar collateral ligament injury risk factors in the elbow? Now, what does that mean? We are going to go along the kinetic chain and figure out where the breakdowns are, and if we can find different methods of decreasing the likelihood of those breakdowns occurring and resulting in UCL injuries. Practice gaps. Ulnar collateral ligament injuries can be devastating. Many of these injuries can be prevented by correcting potential flaws along the kinetic chain. Unfortunately, unlike the lower extremity, there is a lack of research focused on injury prevention of the upper extremity. In turn, there is a need for injury prevention programs targeting the kinetic chain in the overhead thrower. Implementation of injury prevention programs at all levels of competition could reduce the likelihood of UCL injuries in the overhead thrower. What we find in the research is markers along the kinetic chain that predispose athletes to UCL injuries. As clinicians, we need to assess those markers or those risk factors in the kinetic chain and implement exercise strategies to reduce the risk factors associated with UCL injuries. Our objectives today will be based on the kinetic chain and the flaws seen on that kinetic chain. So first we'll discuss basic flaws along the kinetic chain that contribute to UCL injuries. And then we'll describe the logic associated with correcting imbalances along the kinetic chain to decrease injury occurrence. And then finally we'll recognize the importance of injury prevention exercises of the upper extremity. All in all, our goal is to recognize these flaws that occur along the kinetic chain that contribute to risk factors which are associated to ulnar collateral ligaments of the elbow in the overhead thrower. UCL injuries in the overhead athlete have increased greatly over the last decade. Hodgkin et al. Reported that in New York State alone, the rate of UCL reconstruction tripled yearly over a 10-year period from 2002 to 2011. Also, it is estimated that there has been a 10-fold increase in reconstructions in the first decade of the 21st century. What is even more alarming is the evidence that suggests that adolescent athletes are becoming more prone to these injuries. Although there is no national database which has the exact numbers on these injuries, the average has gone up greatly. Speculation of increased specialization, playing for multiple teams, number of pitches, pitching while fatigued are all related to these injuries. One main outlier that needs to be addressed is perception of Tommy John or UCL reconstruction surgeries. There's an alarming growing public perception that Tommy John surgery actually increases velocity. There's no evidence of that. A study done by Ahmad and friends showed that 50% of all high school athletes felt that getting Tommy John surgery would increase velocity, as well as 30% of coaches, 37% of parents, and 26% of collegiate athletes. To go along with that, 31% of coaches, 28% of players, and 25% of parents did not believe number of pitches thrown to be a risk factor. Most preventative measures put in place are designed to decrease pitch counts and exposure to high demand of overpitching. Athletes pitching more than 8 months per year have a 400% increased risk of injury. Those throwing 80 or more pitches per game have a 400% increase of risk of injury. Although these preventative measures have strong research behind them, we are going to concentrate on the mechanical flaws and ways to correct those mechanical flaws along the kinetic chain. Stability of the medial elbow comes from both bony and soft tissue anatomy. We find the bony anatomy to be the ulnar humeral joint, where the olecranon and the olecranon fossa meet. The bony anatomy acts as the primary stabilizers for the medial elbow in the extremes of flexion and extension. We find that the bony anatomy provides stability for the medial elbow from full extension to about 20 degrees of flexion as a primary stabilizer, and as well as in the extreme flexion from 120 degrees to full flexion. The soft tissue anatomy consists of both the flexor pronator group and the ulnar nerve. The flexor pronator group originates off the medial epicondyle and adds dynamic stability to the medial elbow. The group consists of flexor carpi ulnaris, pronator teres, palmaris longus, flexor digitorum superficialis, and the flexor carpi ulnaris. From that group, the pronator teres, the flexor digitorum superficialis, and the flexor carpi ulnaris contribute to dynamic stability of the medial elbow. The flexor carpi ulnaris runs with the ulnar collateral ligament throughout almost the whole entire range of motion. The ulnar nerve passes just posterior to the medial epicondyle of the humerus. From there, it passes through the cubital tunnel and exits the elbow through the two heads of the flexor carpi ulnaris. We find common injuries to the medial epicondyle with medial epicondylitis in that flexor pronator group, and we find some nerve irritation, ulnar neuritis, due to compression or osteophytes and irritation to the ulnar nerve with medial injuries. The ulnar collateral ligament is the primary soft tissue stabilizer of the medial elbow. It is comprised of three components: the anterior bundle, the posterior bundle, and the transverse bundle. The transverse bundle provides little, if any, stability. The posterior bundle provides stability in the extremes of flexion at 120 degrees. The anterior bundle, it is comprised of two subdivided bands of anterior and posterior. The anterior band is the primary restraint to valgus stress up to 90 degrees of flexion, while the posterior band is more important as a stabilizer with the flexion beyond 90 degrees. The anterior bundle originates on the medial epicondyle and inserts on what used to be thought of as the sublime tubercle. However, recent cadaveric dissections have found a new insertion known as the ulnar collateral ligament ridge, which is a broader bony protuberance found along the medial ulnar shaft. When the elbow is flexed, the ulnar collateral ligament provides 54% of the stability against valgus loading on the medial elbow. Also, we find that in the overhead thrower that the highest level of valgus force is between 30 and 120 degrees of flexion, when the UCL is the main stabilizer. This is important to remember as we go over the phases of the overhead thrower and the kinetic chain. We're going to shift gears into the biomechanics of the overhead thrower. Now we're going to go over the 6 phases of the overhead throwing motion, starting with the wind-up, to the stride, arm cocking, acceleration, deceleration, and finally the follow-through. We will go into detail each of these phases and go over some of the flaws found along the kinetic chain in these phases that result in potential UCL injuries. The initial phase is the wind-up. Here the athlete begins in a dual-legged stance and transfers their weight to their rear leg. Here they are in a balanced position. Weaknesses on the rear leg can cause an unstable base of support for the thrower. This can cause a phenomenon called the catch-up phenomenon. We will talk in more detail about the catch-up phenomenon later in this talk. Other flaws such as inadequate knee flexion can cause strain to the medial elbow. Poor balance can cause an increase in forward movement too early in the kinetic chain, which will increase forces on the distal kinetic chain. This also will promote some further risk of injury to the medial elbow. The second phase is known as the stride phase. It starts with the athlete in a one-legged stance, and force is generated towards the target. The front or the stride leg extends towards the target. External rotation of the shoulder, as well as protraction of the scapula, begins in this phase. Hip internal and external rotation become pivotal during this phase. If we find an internal rotation deficit of the stance leg hip, we will probably see an early forward rotation of the pelvis. And what that will do is increase stress on the distal kinetic chain at the elbow. Also, if the stride leg is restricted in hip external rotation, we may see the stride foot placement put in open position, causing increased valgus stress on the throwing elbow. This phase is marked by velocity being generated towards the target and the beginning of upper extremity activation. The third phase is considered the arm cocking phase. Here, enormous amounts of velocity and energy are generated during this phase. The completion of core and lower extremity acceleration occurs, and during the late cocking phase, tremendous amounts of load on the medial elbow and the UCL are created. Weakness or tightness of the stride leg quadriceps can force the knee to be in an altered position and produce an unstable base. This can result in impaired force generation and put further strain on the distal ends of the kinetic chain. Glenohumeral rotational deficits have been shown to put great strain on the medial elbow. We'll go into further detail about arc assessments of the rotation of the glenohumeral joint, as well as the strain put onto the medial elbow caused by that. Hand positioning in this phase has also been shown to put great strain on the elbow. If hand positioning is found under the ball or on the side of the ball, a great valgus strain is placed on the elbow. The fourth phase, the acceleration phase, we see in the beginning of this phase acceleration of the upper extremity and large amounts of stress placed on the UCL. We find the shoulder in maximal external rotation, and this phase ends when the ball leaves the hand. During this phase, energy continues to transfer from the core through the upper extremity. At the start of this phase, the elbow initially flexes from 90 degrees to 120 degrees of flexion, and then rapidly extends to just prior to release of the ball. Here it is important to see throwing arm in what is called a high elbow at 90 degrees of shoulder abduction. If the throwing elbow is dropped below 90 degrees of abduction, this position can place an increased valgus load on the elbow, predisposing it to medial elbow injuries. The deceleration phase, or the fifth phase of the throwing motion, is highlighted by ball release and large amounts of eccentric contractions to decelerate the forces that were generated during the kinetic chain before ball release. This phase starts when the ball leaves the hand and ends when the shoulder is in maximal internal rotation. Because of the high loads of eccentric contractions, most overuse injuries are found during this phase. It is during this deceleration phase that the internal rotation deficit occurs. Those internal rotation deficits do cause valgus strain on the elbow if left untreated. We will go over how to assess rotational deficits and what type of exercises that will help to combat any kind of deficits along the shoulder rotation. The sixth and final phase, the follow-through phase, is noted with weight transferring to the lead leg and motion concluding. Here we see the stride leg absorbing the force of the throw and adding stability, and the stance leg, or the rear leg, is brought to the ground in a follow-through motion. The pitcher or thrower is then ends up in a fielding position. Eccentric contractions continue to decelerate the arm at both the shoulder and the elbow. Large amounts of eccentric contractions still occur, not at the rate as they did in the deceleration phase. However, overuse injuries are found in this phase as well, just because of the amount of eccentric contractions to decelerate the motion that was generated throughout the kinetic chain. The kinetic chain is an important concept to understand when dealing with the overhead throwing athlete. It's predicated on efficiency to generate and dissipate forces. Basically, it temporarily links the segments of the body included in the phases of throwing. Breakdowns or deficits in the kinetic chain result in risk factors for injury. 8 nodes were recognized by Kibler et al. To effectively achieve the overhead throwing motion, but more importantly for our purposes today, as a potential marker for deficits in the kinetic chain. These positions include trunk control over the rear stance leg, stride, front leg directed towards home plate, hand on top of the ball in the arm cocking phase and continuing through the acceleration phase, control of the forward lean and lumbar lordosis in acceleration phase, hips facing home plate after stride phase and continuing after ball release and deceleration, arm cocking composed of scapular retraction, arm horizontal abduction, shoulder external rotation, high elbow above shoulder until after ball release, along with long axis rotation during ball release. Force development in the large muscles of the legs and the core produces about 51 to 55% of the kinetic energy that is transferred to the hand. With velocities of 7,000 degrees per second in the shoulder, funneling torques at the elbow of nearly 100 Newton metre, any deficits along the kinetic chain can cause changes that increase risk factors to the medial elbow. There are 244 possible degrees of freedom from the foot to the hand. Discussing all of them would take days. We will focus on the deficits that are most commonly related to risk factors of the UCL. When we look at the breakdowns in the kinetic chain, we see that they coincide with the phases of throwing. We want to look at where do they most commonly occur to place risk on the UCL. Also, how can we screen for these deficits that occur on this kinetic chain? And finally, how do we correct these flaws and introduce preventative measures to decrease the likelihood of risk of UCL injuries? If we can effectively screen the individuals that have kinetic chain deficits, it may help to identify individuals who are at increased risk for injury and allow us to properly implement interventions to prevent injury. It is essential to do some screening processes in the preseason to identify these athletes and implement exercise strategies to prevent these risk factors. We're going to start by examining the hip and lower extremity strength and flexibility and how it correlates to breakdowns in the kinetic chain that will affect the UCL of the elbow. To first understand this, I think we first have to look at the catch-up phenomenon. So basically what the catch-up phenomenon is, we briefly spoke about it earlier in the talk, but deficits in the kinetic chain contribute to what is called a catch-up phenomenon, and basically what that is breakdowns in the kinetic chain that cause stress and increased demands on distal segments. So starting from the ground up, and we're looking at hip and lower extremity strength and flexibility. If we have hip weakness, we're going to need to generate more force at the distal segments to compensate for that hip weakness. So that's basically what the catch-up phenomenon is a way for the body to make up for deficits in the proximal end of the kinetic chain. Also, The hip and lower extremity help to stabilize the lead leg to optimize transfer of energy along the kinetic chain. So again, we're working from the proximal to the distal. The more balanced and strong we are in the hip and lower extremity, the less stress put on the distal segments of the kinetic chain. Endo and Sotomato, in a longitudinal study of throwing athletes, found that athletes in a pain group, which experienced shoulder or elbow distal kinetic chain pain, had significant increases in tightness of the quadriceps and the hamstrings in the stance leg over the period of a season. They also found that preseason or early season, these athletes had decreased external rotation of the hip and tightness found in the stance leg of the quadricep. This all contributes to the phenomenon that we discussed before, that proximal segments that may have deficits in it will contribute to pain or injury towards the distal end of the kinetic chain. When assessing the hip and lower extremity, Cole et al. Feels that when assessing the lower extremity, it should be done in a closed kinetic chain to make it more functional, that you could not pick up deficits along that kinetic chain in an open chain forum where you are assessing hip range of motion and knee range of motion. That the closed kinetic chain is the more optimal way to pick up deficiencies in the kinetic chain assessment. So if we find deficiencies in the knee extensors, we will see decreased stability and impaired kinetic chain energy transfer, and which could lead to the catch-up phenomenon and the overuse of the medial elbow. When looking at the hip, if we have hip total arc range of motion deficits, the foot positioning when on contact could be open or closed. Especially in the open position, this will cause the arm to lag across the body and put significant strain on the medial elbow. With hip weakness, gives another unstable base, just as the knee extensors would, and that in turn would help cause the catch-up phenomenon, which would also put strain on that medial elbow. Weakness in the hip musculature, in the abductors and the adductors and the hip flexors, could cause premature opening or a forward pelvic rotation, which in turn increases the demand on the distal kinetic chain and the medial elbow. So how do we assess these? Simply in the athletic training room, we can use a single-legged squat to assess for knee extensor weakness and hip weakness. We can do this by just assessing to see if there's a corkscrew type motion of the knee, which would cause the knee to adduct towards the midline and medially rotate for abductor weakness, and inability to do the fixed single-legged squat could also be caused by weakness in the knee extensor. Assessing the total arc of the range of motion of the hip, again, should be done in a closed kinetic chain to mimic more of a functional position of the overhead kinetic chain. Exercises that to include to combat some of this dysfunction would be dynamic hip flexibility stretching, lunges, adductor lunges, straight leg toe touches, all in a dynamic stretch, as well as single-legged squats. Although that's the test to decipher whether there's knee extensor and hip weakness. Sometimes the test can also be the exercise, and single-legged squats should be included to increase knee extensor and hip strength. Another great exercise to include is the Copenhagen adductor exercises. This is a partner exercise that was found to increase abductor and adductor strength. Ishoy et al. Found that the Copenhagen adductor exercise increased hip adduction strength by 35.7% and increased hip abduction by 20.3% in an 8-week supervised resisted training program. Considering the effectiveness of this exercise and the relatively easy method of partnering to do it, it is an essential component to add to preventative exercises in the overhead thrower. All right, now we're going to go over the Copenhagen adductor exercise. This exercise has been shown to increase adduction strength in the hip as well as abduction strength in the hip. The idea behind it is, as a partner exercise, you're going to have the partner hold the top leg. As the athlete goes into a side plank, they're going to abduct their top hip into a plank position and then pull their bottom leg up into adduction and then back down and to the ground. You're going to do sets of 10 to increase both hip strength and stability. Core strength and flexibility, along with postural control, has been related to injuries along the kinetic chain, in particular the UCL. When you have weakness or inflexibility in the core, again, that can cause the hips to open to home plate, putting stress valgus load on the medial elbow. It also helps or increases the catch-up phenomenon, which we already had talked about, that where proximal deficiencies will cause stress on the distal end of the kinetic chain. Also, Garrison et al. Found poor performances in the Y balance test between athletes suffering from UCL injuries versus a healthy control group. He found a 6% difference in both lead leg and stance leg as compared to a controlled group, healthy controlled group. This shows us that the postural and core strength lacks in the athlete suffering from a UCL injury. Screening for these athletes, we must keep in mind that Chowdhury et al. Found that professional pitchers that had poor lumbar pelvic control were 3 times more likely to miss at least 30 days throughout the course of a baseball season relative to those who showed stronger control. Assessing bilateral trunk range of motion is critical in distinguishing whether or not there are deficits along that kinetic chain that could cause distal loads that will result in injury. Utilizing the star excursion test to predict deficits in postural control and balance has been shown to be efficient. Endo et al. Found that 90% of the variance seen in medial and lateral lower extremity reaches were found in the sagittal plane of motion. Also, Plitsky et al. Found that only the anterior reach was significant in predicting injury, with a difference from side to side of 4 centimeters, making the athlete 3 times more likely to be injured. Finally, we're going to use a single-legged stance for balance to assess postural control and balance. This is a functional position seen in the overhead thrower, standing on the rear leg. You were going to check for a Trendelenburg sign to see if there's any weakness in the glutes, as well as balance and postural sway of the athlete. Cole et al. Found this as a great functional assessment tool to identify deficits in balance, postural strength. Here are a few videos identifying these screening tests and how you can conduct them in your athletic training room. Okay, now we're going to go over the STAR excursion test. The STAR excursion test, as we explained earlier, is a good exam for postural deficits as well as hip and lower leg strength. What we do is we can do this very simply in an athletic training room. All you need is white tape, a measuring stick, and you can build your own STAR excursion plot. So in order for it to get accurate, you want to have the athlete stand with their midfoot in the middle, and that's going to be your measuring line. You're going to have them plant on their stance leg, and they're going to reach forward with their opposite leg towards as far out as they can without touching. Okay. Now they're going to come back and they're going to do it again. Okay. And they're going to come back and do it again. Okay. They're going to do it 5 times. All right. And then they're going to switch legs. And what you're going to do is measure the difference. Okay. Good. Go all the way back. That's okay. Good. Okay. Good. All right. And what you're going to do is you're going to measure this difference between the two, and if there's a greater difference of 4 centimeters, then they have a postural or a lower leg deficiency. Now we're going to go over a single-legged stance postural evaluation of an overhead thrower. Basically, we're going to put them in the wind-up phase of the throwing phases and assess if they have any deficits in that position. The biggest thing we're going to look for is to see if you have a Trendelenburg finding in the athlete. So what we're going to have them do, and you can give them clues, you're going to have them pick up their lead leg, shift all their weight to their rear leg. They're going to be in about 90 degrees, a little further, in a high stance. They're going to bring their hands together like they're going to throw. You're going to assess for a Trendelenburg, and you're going to have them hold it for 30 seconds, all while you're examining any postural exams, swaying, decreased balance. It's all important to make sure that we don't get this postural problem so that we have the catch-up phenomenon occur from this position. Identifying exercises to combat deficits in postural control and balance. Trunk stability can come from the simple plank as well as a side plank with rotation, which will incorporate the obliques, external and internal obliques. In addition, utilizing the STAR excursion test as an exercise, as we said before, sometimes the test is the exercise, and including some simple balance type exercises, single-legged ball tosses, so the athlete stands on their dominant leg and has a catch with their teammate, throwing the ball back and forth on just a single-legged balance. As well, incorporating an L hop, which would be an anterior hop, and then a lateral hop, keeping balance in a dynamic fashion. A lot of the exercises we see for the hip and lower extremity cross over to the postural and balance control. So when dealing with these two parts of the kinetic chain, we will see a crossover with the exercises and the screening tools. Another exercise that we can include for both core and hip strengthening as well as oblique strengthening is the side plank with rotation. What we're going to have the athlete do is stay aligned. They're going to plank up on their forearm and do a side plank position. Make sure they're aligned. They're going to take their their top hand up in the air. They're going to rotate that hand underneath their body, almost like they're giving themselves a hug, and then rotate back up into a full extension position. You're going to have them do sets of 10 on both sides. And that at shoulder, elbow, range of motion, and strength. As we journey down the kinetic chain, we will see that deficits in the proximal end of the kinetic chain will affect the distal kinetic chain. We'll also see changes in that distal kinetic chain that will result in injury risk factors. Much research has been done in total arc assessment related to the shoulder internal and external rotation as it affects elbow valgus movements. Wilk et al., in a study of overhead throwing professional athletes, found that there was a 2.6 times greater risk of UCL injuries in pitchers with a total arc difference of 5 degrees from the non-throwing side to the throwing side. In the same study by Wilk et al., pitchers with a deficit of greater than 5 degrees of flexion from the throwing shoulder to the non-throwing shoulder had a 2.8 times greater risk of injury of the UCL. The flexor pronator group is the dynamic stabilizer for the medial elbow. Weakness here puts UCL at risk for injury. Many times this weakness is found from fatigue from overthrowing. On assessing these athletes, total arc assessment is crucial. Szymanski et al. Found that a side-lying position was more reliable than the supine position when assessing total arc of the athlete. Through the use of a bubble inclinometer, we assess both the internal and external rotation and add those together to compare to the throwing side to the non-throwing side to get our difference in total arc assessment. In addition, it's imperative to assess the passive forward flexion of the glenohumeral joint. Here we use the athlete laying supine and utilize a goniometer assessing any difference in forward flexion between the two in a passive range of motion. Now we're going to go over total arc assessment to rule out deficits in range of motion in the shoulder. It's very important to align the athlete properly. Make sure their acromion processes are lined up from top to bottom, so from assessment side to non-assessment side. Have them place their palm on the table in front of them, hips in a neutral position, shoulder at 90 degrees of flexion, elbow at 90 degrees of flexion. We're going to assess internal rotation first. So we're going to put them in an internal rotation spot. We're going to make sure that their assessment side scapula is adducted. And then we're going to take our bubble inclinometer and we are going to assess for internal rotation until we get to an end point or pain starts. We are then going to put the athlete in external rotation. Same thing until we get an end point. And we're going to add the two together to get a total arc. Now we're going to assess the other side. Normally, we would assess the throwing side first. Make sure when you're assessing the contralateral side or the non-throwing side, the non-dominant side, you take the same steps that you did earlier with the throwing side. Make sure that the shoulders are aligned. Make sure that hips are neutral. Make sure that you also are adducting the scapula as you go to test for internal rotation first. Shoulder at 90, elbow at 90. You're going to get to a point where you feel the end range of motion or pain. You're going to use your bubble inclinometer. And then you're going to put the athlete in external rotation so you get an end point. elbow inclinometer, and you're going to take the total arc, add them together, take the difference between the throwing side and the non-throwing side, and if you have a difference in 5 degrees or more, your athlete is predisposed to UCL injuries of the elbow. Exercises to combat deficiencies found in the shoulder and the elbow should start with sleeper stretches. Burkhardt et al. Found that 90% of all throwers will improve to an acceptable level of internal rotation from just 2 weeks of sleeper stretches. Here we see the sleeper stretch is a staple in all upper extremity injury prevention programs, as we see the significant numbers correlated to total arc loss from throwing side to non-throwing side and the incidence of UCL injuries. Also, suggested stretches such as partner stretches for external rotation and forward flexion, which can be accomplished utilizing an immovable object to increase passive forward flexion as the athlete leans forward and increases forward motion. Finally, a grip and wrist flexion and strengthening exercise to address flexor pronator weakness. We can utilize dumbbell exercises to increase strength, or utilizing sand or buckets of rice to do functional motions with resistance from the sand or the rice. As with all the suggestions for exercise, these are just suggestions. It is important for the clinician to find the most optimal way to implement strategies to decrease the deficits found along the kinetic chain through different exercises. Okay, now we're going to go over the sleeper stretch. The sleeper stretch has been shown to dramatically increase internal rotation. So if you have that athlete with the internal rotation deficit, this is a great exercise. What you're going to do, much like the total arc assessment, you're going to have the athlete in a neutral position. You're going to flex the hips to 90 degrees, knees flexed. You're going to have the athlete with their shoulder in 90 degrees of flexion, elbow in 90 degrees of flexion. You're going to have them take their opposite hand and put themselves into internal rotation, making sure that their back is slightly retracted in the scapula and their acromion processes are lined up top to bottom. They're going to hold this position for 30 seconds, and they're going to do this 3 times. After they do this 3 times, they're going to move their shoulder into 110 degrees of flexion. Make sure that they keep their scapula aligned, slightly retracted, and they're going to push down again into internal rotation. They're going to hold that position for 30 seconds and do that one as well for 3 times. Then they're going to end up finally in 70 degrees of glenohumeral flexion, elbow still at 90, scapula is positioned properly, and internal rotation. So we're going to hit 3 different angles for the shoulder. You're going to do that 3 times, 30 seconds as well. How do we close the loop? Let's recap the evidence we know about the kinetic chain and the deficits that put the UCL at risk. We see that proximal deficiencies cause a lot of strain on the medial elbow. So in order to combat that, we need to implement exercise strategies as a preventative measure to decrease the likelihood of these injuries or these risk factors. Assessment should occur prior to preseason, but not be limited to just preseason. We should assess the athlete during the season and towards the end of the season to see if deficiencies occur during the season from either overuse or improper mechanics. Implementation of an injury prevention program should be done as soon after assessment as possible to address the risk factors prior to the preseason. These should be revisited during the season to see if any more deficiencies occurred, putting the athlete at risk. So closing the loop, we have the information where these deficiencies occur and how likely they are to be a risk factor for UCL injuries. We also understand how to assess these deficiencies and also some examples of injury strategies to combat these deficiencies. Now we must put it together, find the most optimal way to put that injury prevention program in place, and make sure that the athletes are being compliant. By utilizing this strategy, we should see a decrease in UCL risk factors seen in our overhead athletes. Take-home points. Development and implementation of preventative measures for the overhead thrower lacks greatly. We don't see actual studies like we do in the lower extremity for injury prevention programs consistent with the overhead thrower. This is definitely an area that needs to be researched a little further. These are specialized athletes that we're dealing with. They place high demands on the structures of the upper extremity, especially the UCL, considering that's one of the most distal segments of the kinetic chain. By utilizing this research to view deficits along the kinetic chain that are consistent with UCL injuries, we can help prevent this escalating problem and keep our athletes on the field where they belong.